All right. Hi, everyone. My name is Justine Coe. I'm one of the MedStar Georgetown EM Fellowship graduates, and I'll be reviewing Epistaxis with you all today. This is something that we see pretty often within the emergency department, but it's certainly something that you guys will probably encounter on the sidelines, and hopefully this will be a quick review of the techniques and resources that can be used to manage epistaxis. So there are plenty of ways to control epistaxis. Many of these you guys already know. This ranges from direct nasal pressure, chemical cauterization with silver nitrate, foams and gels, and then some nasal packing. And that can range from balloons to things like rhino rockets, and we'll go over all these a bit later in the presentation. So how can you control epistaxis? I know you all know this, but it's especially important to coach our athletes through the proper way to hold pressure when they do have a nosebleed. And so one thing is that people tend to hold their nose a little bit too high up, and so there's really not a lot of pressure to the mucosal surface, and really they're not doing anything. So when I have a patient or athlete with a nosebleed, the first thing I tell them is to blow their nose to expel all the clots. This leaves me with kind of a fresh mucosal surface. This way I can apply things like a nasal constrictor. The most common one I use is Afrin. And so once they blow their nose, expel all the clots, I'll be able to spray some Afrin up their nose, and then I have them hold pressure. And usually, and I know you guys know this, you hold it both below the cartilage and you hold it very, very tight. I will usually show them how much pressure I'm holding and then have them take over. This way they have a sense of how tight they need to be holding it, and then have it hold it for 10 to 15, 20 minutes before I even check. And I tell them no cheating. Otherwise, you're going to have to reset the clock and start all over. The other point is most people were, for some reason, taught by their grandmothers or whoever to lean back, and that's not good. So I always tell them again to lean forward while they're holding pressure. This way they don't swallow any of the blood. This way they don't get nauseous and throw up. You especially don't want that on the sideline either. Chemical cautery, the most common one being silver nitrate. This is something I'll use judiciously. What I mean by that is not every athlete who has a nosebleed is a good candidate for this. Usually I will only use it if the bleeding has stopped pretty significantly, but I can still see where the bleeding was coming from, meaning I saw a little bit of oozing from the likely culprit, and then I will attempt. The silver nitrate wand, you kind of just hold in the area that you think the bleeding is coming from, and you hold it there for a few seconds. It is super important to only do this on one side. If you do it on both sides, you risk potential perforation. It's not a great look. So make sure if you're going to do this that one, you visualize what you're going after, and two, you only do it on one side, which is what most nosebleeds are anyway. They usually are unilateral. If that doesn't work, so if direct pressure cautery doesn't work, you can use nasal tampons or sponges. These are usually some sort of synthetic material that will expand after hydration. So you can see this is the one pre-hydration, and this is after it's expanded. The most common one is probably Miracell that you'll see. Some come with a string attached, some don't. If you don't see a string attached, just take some sort of suture and tie it so that the suture hangs out. This way, once you insert it into the nasal cavity, you'll have a much easier time removing it down the line. And remember, you're gently inserting this along the floor of the nasal cavity. You want to kind of aim for the back of the head and not upwards, because that's the way the the floor goes, and you'll have a much easier time inserting the actual Miracell. This will usually slowly start to expand once you insert it. If you are having issues and it's really not expanding, you can always take like an angiocath with some normal saline and gently irrigate that. And usually it'll kind of expand to this side, fill up the nasal cavity, and provide some tamponade effect. Thrombogenic foams and gels. These can be inserted similar to the tampons that we talked about earlier. However, they don't come in kind of like a pre-made Miracell shape. So usually you'll have to kind of cut it or twist it and kind of form the gel foam or the Surgigel to the nasal cavity. These are hemostatic devices, and so hopefully they can help with stopping the nosebleed. There are now some bioabsorbable ones that do not need to be removed. These ones, once they're inserted, become like a gel-like substance within 24 to 48 hours, and then generally speaking, within about 1 to 2 weeks will dissolve. And the thought process is that because they dissolve, you don't really need systemic antibiotics and you don't need to remove them, so theoretically they're easier. I will say, from the emergency medicine side, we rarely see this because they're more expensive, and usually the Miracell, Afrin, holding pressure, and the packing that we'll talk about in just a second here really does a trick. So anterior epistaxis balloons, there's a bunch of these, the most common one being rapid rhino or rhino rockets. They're essentially more on the last line spectrum of things to try before more invasive methods. And so the rapid rhino or the rhino rockets come in 3 different sizes. There's a 4.5 centimeter, the 5.5, and the 7.5. Generally speaking, 4.5 and 5.5 are for anterior nosebleeds, and 7.5 is for posterior nosebleeds. These are cellulose-coated tampon-like balloons that tend to expand after you soak them in sterile water for 30 seconds. It's important that sterile water and not saline. If you ever forget the packing itself, the labeling does say use sterile water. And once it expands, you can insert it just like you inserted the nasal tampon and sponges that we talked about earlier along the floor of the nasal cavity. Usually after you insert, many of them have some sort of a balloon that you can also inject air into. So you're injecting 10 to 20 cc's of air, and you're really titrating it to, 1, make sure it has a good tamponade effect, but also 2, you want to make sure that your patient is not too miserable, because otherwise they're going to come right back, or there'll be other issues. And so you want to make sure it's enough to stop the bleed, but also somewhat of a comfort thing for the athlete or the patient. Posterior nosebleeds, these are ones that are very scary, and hopefully this doesn't happen to anyone. You see more commonly in those on blood thinners, elderly people, people with recent procedures, which hopefully you as a team physician will probably know about. But even though they're more rare, it is important to know how to manage them. And so, as we talked about a little bit earlier, with the rhino rockets, if it's a posterior bleed, you want it to use a 7.5 one. And you want to think about posterior bleeds if they have blood coming from both nares, like pretty profuse blood coming from both sides, or even after anterior packing, you're still seeing a pretty significant amount of bleeding in the posterior pharynx and going down the throat. So just think about posterior bleeds. As I mentioned again, the rapid rhino 7.5 centimeters is the one that you want to use. If you don't have that, a Foley can also be used. A 12 or 14 French Foley can be inserted to the back of the nasal cavity, inflated with 20 to 30 cc's, whatever the balloon can tolerate, and then you can kind of pull a little bit of downward traction to tamponade. These do have a higher complication rate, so you can risk necrosis, there can be higher rates of infection, and because there's a pretty significant amount of bleeding, and oftentimes they might be on blood thinners, this can lead to significant hemoglobin drops and other complications. So it's important to, 1, try to get the bleeding under control, and 2, consult our ENT colleagues soon. This is just an image showing the posterior packing. So as you see with the rapid rhino as well as the Foley, it's posterior bleed, so these are inserted very posteriorly, and so quite uncomfortable for the patient. You also see sometimes with the posterior nasal packing, there might be 2 balloons to inflate. but every packing is a little different. Usually they'll have an image or some sort of guidance on the packing itself. And then for anyone with packing, it's important to start antibiotics to avoid infectious complications down the line. Most literature will say you should only do this if it's bilateral nasal packing and not unilateral, but our ENT colleagues still, many prefer the antibiotics even with unilateral packing. So the most common one is augmentin. Have them discontinue their NSAIDs. Anyone with anterior epistaxis can be discharged home with close ENT follow-up, but posterior packing should be likely admitted for observation and definitive management to make sure that they don't continue to bleed posteriorly. So for the last little bit, just going to talk about nasal fractures. It's the most common facial fracture, and you probably will end up seeing at least one of these. Most are isolated and usually associated with some sort of nosebleed. But if it's a more serious injury, just think about other concomitant injuries like concussions, C-spine injuries, other facial fractures like Lafort injuries. Just keep those in mind. And when you're examining, look for crepitus, a deformity, ecchymosis. Generally speaking, if it's isolated, you do not need any sort of imaging, and reduction can be performed, but does not necessarily need to be performed emergently. A key point during your exam for nasal trauma or fractures is to check for septal hematomas. Usually just have the patient look up, and I'll use my flashlight or one of the otoscopes to take a look inside their nose and check for a septal hematoma. If there is a septal hematoma, it is important to perform an incision and drainage. And so it's a small horizontal incision. Kind of drain it out and then insert a wick or some sort of packing to prevent premature closure of that incision and reaccumulation. And then often you'll do bilateral anterior nasal packing, again to prevent reaccumulation. But because it's bilateral, it's super important to do the antibiotics with augmentin and have really close follow-up. Usually the bilateral nasal packing should be seen within 24 hours. So if you have someone who's affiliated with your team, be sure to just give them a heads up that hey, I'm sending you someone with bilateral nasal packing. And this is just an illustration to show you the incision and drainage process. Here again you can see the nasal hematoma or the septal hematoma. And so they're making a horizontal incision here. This is showing a drainage. In this case, they decided to use iodoform packing, it seems, and not a wick. But I personally have maybe seen this once. And so it's pretty rare, but it's something that you should know how to do because if you see it, it does require drainage. So to kind of wrap up and summarize, if you have epistaxis, fine and septal bleeding, we reviewed several options, including cauterization and packing. If you leave any sort of packing in the nasal cavity, be sure to prescribe antibiotics, most common one being augmentin. Be mindful of possible concomitant injuries, check for facial fractures, and in the setting of trauma, always check for possible septal hematoma. Thanks, guys. Have a great year.